Can you hear me all? Can you all hear me? Assalamu alaikum and good morning. Welcome to the ICON 2022 second day scientific session of nephrology. So earlier we had a very wonderful session with Dr. Mubarak and Dr. Wakar. Today in this session we again have three panelists and two talks. The first talk is by Professor Joanne Bargman. She is Director of Peritoneal Dialysis Program and Co-Director of the Combined Renal Rheumatology Lupus Clinic for the University Health Network, Toronto. She has a vast contribution in important subjects of nephrology like peritoneal dialysis, glomerulonephritis, and lupus. She has also been awarded a number of awards in recognition of her contribution towards nephrology. For Day 2 ICON 2022, she is covering a very interesting topic, challenges in the management of resistant lupus nephritis. This session is chaired by Professor Dr. Ijaz Ahmed, Senior Consultant Nephrologist from Sindh Institute of Urology and Transplantation, Karachi. Welcome, Professor John Bargman. Can you hear me?
Yes, I can.
Excited. Good morning, Professor John Bargman. Can you hear me?
Yes, can you hear me?
Yes, I can.
Sorry, I just lost you. I have to try again. I'm going back into the room. And is there an icon to share the slides?
Yes. Would you please share your screen, your slides?
Okay.
Eco. I cannot hear you. Sorry for the inconvenience.
Can you hear me now?
Yes, I can.
Okay. Every time I click unmute, I lose the picture. Can you tell me how to share my slides?
How can she share her slides? She is having some problem in sharing her slides. Are you sharing your screen on the same computer you are online from?
Yes.
She's sharing from the same computer.
And by the way, StreamYard, which seems to be the broadcast studio, keeps coming on with advertisements.
Can you see screen share option at the bottom of the screen?
It says share.
Yes.
Okay. I just want company. Can you hear me? Can you hear me?
Yes, I can.
Okay. Live Duck keeps coming on with advertisements and it shuts off this communication. I've had to relog on about 4 times now because after the advertisements, just for future. Anyway,
Welcome back. Sorry for the inconvenience, and now we are back. Dr. Bargman, can you hear me?
Yes, can you hear me?
Yes, I can.
Oh, perfect.
Okay. Okay. I cannot see the screen. I cannot see your screen. Okay. Please start your slide share.
It's being shared.
Please start your presentation.
It's up. I hope if you can't see it, I don't know what else to do.
Yes. It is shared now.
Okay.
Presentation.
So we're good?
Yes, please.
Okay. Do you want me to start or is someone going to introduce me?
I've already introduced you. Let me introduce you again. So
No.
we have so we have Professor John Bargman, Director of Peritoneal Dialysis Program and Co-Director of the Combined Renal Rheumatology Lupus Clinic for the University Health New Network Toronto. She has a vast contribution in important subjects of nephrology like peritoneal dialysis and lupus. She has also been awarded a number of awards in recognition of her contribution towards nephrology. Today, she is covering a very interesting topic, challenges in the management of resistant lupus nephritis.
Thank you very much. And thanks very much for asking me to talk about resistant lupus nephritis. It actually was a very good opportunity for me to formulate my thoughts around this. And I'm very happy that I did it. And I hope that you will be happy with results. So I'm telling you some true stories, which certainly have been very instructive to me. This is a patient. I wasn't involved in her care. A young woman, socially isolated, very high risk for social problems. And she had a long history of lupus, lots of flares, which were brought on by non adherence. And she hadn't shown up to her lupus clinic for a couple of years. And one of the things you learn is if the patient doesn't show up, it means that they're not taking their medicine. And then she had a dramatic presentation to the hospital in December of 2017. And I was not involved in her management, excuse me, but she was given follow up in our combined renal rheumatology clinic. So we evaluated her in the renal rheumatology clinic, and I went over her discharge medications from hospital. So she was on 40 milligrams of prednisone, 1,080 milligrams of myfortic twice a day, hydroxychloroquine 400 milligrams daily, and ramipril 2.5 milligrams to help so-called hemodynamically reduce proteinuria, atorvastatin because her lipids were elevated. She had some hemolysis at her presentation, so she was put on folic acid, iron, pantoprazole for gastric protection, Septra for pneumocystis prevention. In hospital, she had been tachycardic, so she was put on beta blocker. Vitamin B12, I presume also for the hemolysis, calcium, and vitamin D. So this non-adherent, socially isolated young patient was discharged from hospital on 31 pills a day. Now, one of the things I learned as a medical student is that better can sometimes be the enemy of good. And we know from the hypertension and other literature that the more medicine you prescribe, the more complicated the regimen, the lower the adherence to therapy. In my mind, the most important medicine at the presentation of lupus or flare of lupus is prednisone. And so really you need to focus on that and perhaps their second disease modifying agent, but to me the prednisone. And in this kind of a patient, instead of 31 medicines, I may have given one 50 milligram tablet of prednisone and said, take one of these every day. I couldn't guarantee adherence, but I think it would increase the odds. So perhaps not surprisingly, she was no-show for her follow-up clinic, the one after the discharge. And then what I heard is she presented to another hospital with acute chest pain and died. And I don't know if that was a PE or a heart event or whatever. So very sad story, but 31 pills to this patient was really the point of the learning here. Now, this is a patient that has troubled me for years and really opened my eyes. This is a young man who again presented with lupus. He was treated appropriately and slowly got better, slowly had a taper of his corticosteroid, still had residual proteinuria, which we will talk about, but his kidney function normalized, which was great. And he was sent to me for his follow-up. A couple of years later, while I was following him, he had a pretty clear lupus flare with, as you can see, proteinuria and markedly depressed serum albumin. And I restarted him on 50 milligrams of prednisone a day and put him back on induction doses of MMF. But nothing got better. First of all, he was tolerating the flare quite well. Despite having that low serum albumin, he didn't have any edema, but he didn't look Cushingoid at all, although he swore that he was taking his prednisone. And nothing got better. The serology wasn't getting better. Nothing was getting better, but he swore to me he was taking his medicine. And then one day he had the sudden onset of chest pain, increased troponins, and this 25-year-old man developed an acute non-ST myocardial infarction. And he was admitted to the coronary care unit. I guess the reality of everything must have struck him when he was admitted to the coronary care unit. And the cardiologist rounded on him the next morning. And guess what the patient said to the cardiologist? I've never taken my lupus medicines, ever. So that really was a wake-up call to me. Another example of resistant lupus is a phone call that I get very often. I have a patient with lupus nephritis who I treated with MMF and they aren't getting better. Should I use Rituximab? So first of all, there is no mention about the protocol for the corticosteroids or whether the patient was taking the corticosteroids. And as I mentioned, that's really the most important medicine at the outset of the disease or a flare of the disease. And it's not getting better in how long? Are we talking about a week, a month, 6 months, a year? So it takes a lot longer for lupus to get better in many patients than what we're expecting. And we may call it resistant lupus, but it's really because we're just not waiting long enough. This, for example, is from the Toronto lupus cohort, and it shows recovery of proteinuria. On the x-axis, I want you to note the axis. It's years, and it goes out to 10 years. And on the y-axis is the percentage of patients with normalized proteinuria. And I just want you to see the kind of timeline we're talking about here. And this is a very similar looking slide from Ponticelli's unit in Italy. Again, please focus on the axis here, the x-axis of 5, 10, 15 years. And especially in membranous, it can take a really long time for proteinuria can resolve. Same thing with resolution of microhematuria. It can take much longer than you think it can. So don't mistake resistant lupus with the fact that you just haven't been waiting long enough. And you've got to reset your mind to months to years, not days or weeks to months. So lupus is not minimal change disease. It takes a lot longer for the proteinuria to resolve. It can take a lot longer for the GFR to resolve. So, as I said, don't label nephritis as resistant because it's not getting quickly as fast as you would like. And get comfortable with this idea of residual proteinuria, that although the lupus is actually successfully under treatment, there may be residual proteinuria, and you don't have to necessarily change or intensify the immunosuppressive therapy. So, what does KDIGO have to say about this? This is their decade-old one that troubled me for many years. They said, first of all, you may want to repeat a kidney biopsy to make sure that it's not a class 6 or scarring lupus. And basically, it had not much to say. If you're using one drug, consider using a different one. Consider adding on Rituximab or calcineurin inhibitors or IVIG. And you can see these are all just throwing up your hands and saying, I don't know what to do. And I'll come back to this because I think sometimes there isn't a whole lot more to do for truly resistant lupus nephritis. So my quibble about the resistance in the 2012 guidelines, that there was no mention of the number one cause of resistant lupus in my mind, which is non-adherence to therapy. And you should think of that if the patient isn't starting to look Cushingoid. Think about it if the serology is not improving at all. Like I said, it can take a long time for the kidney stuff to improve, but you should see the complements start to increase if they were suppressed at the time of presentation. Hemoglobin also seems to be one of those metrics that increases more quickly. So things should be improving in that kind of direction. Also, the patient should be able to tell you how many prednisone tablets they take every day. In Canada, they come in 5 milligram tablets. So if someone's on 40 milligrams of prednisone, they should be able to tell you right away that they're taking 8 tablets of prednisone. And if they can't, it increases my suspicion that they're really not taking their medicines. So after the 2012 guidelines, I basically went on a campaign saying that they missed the boat in terms of the commonest cause of resistant lupus. And I think it worked because now the revised guidelines, the first recommendation is to check for adherence. If you're lucky enough that you can check levels, then you can do that, or you can call the pharmacist, things like that. But it really does point to non-adherence to therapy as the cause of the resistant lupus. So how do you increase adherence? Outside of keeping the pill count low, which I already mentioned, I don't know. I think, at least in my part of the world, many patients are not told that lupus is a life-threatening disease. If they were told they had cancer and they had to start taking chemotherapy, they know just from public knowledge that they're going to feel bad, that their hair's going to fall out, things like that. But I don't think anyone does this with lupus. So I tell my patients that being diagnosed with lupus can be the same as being diagnosed with cancer. And you can die of this just like you can die with cancer. And so they have to go through a bad phase with treatment until they're better, but they will come out at the other end of this in better shape. So again, where cancer has a clear indication of something bad going on, this may not be the same for lupus. And so it's up to us to educate the patient about that. And then maybe they would be more willing to take medication with side effects. And the other thing is that patients will lie to you. So don't take it personally, but they may look at you in the face, swear that they're taking their pills, and they're lying. Remember, you can often, at least in Canada, contact the patient's pharmacist who can tell you how often the medications are being filled and refilled. So in the truly adherent patient, which I think is a minority, who has truly resistant lupus, I don't think, first of all, it's all that common. And sadly, I don't think that there is any magic bullet, although I'll go through some newer agents briefly. Very important, you have to remember what Galen said, And he said something that boiled down to everything works in mild disease and nothing works in severe disease. And unfortunately, I think that applies to lupus and lupus nephritis. So, what about calcineurin inhibitors? This became sort of the therapy of du jour, so-called multi-targeted therapy, which was basically the addition of a calcineurin inhibitor to MMF with corticosteroids. I suspect that a lot of the positive studies with calcineurin inhibitors are only the result that they reduce proteinuria, and they may reduce proteinuria in a non-immunologic way, and therefore it's just a temporary reduction of proteinuria. We know that the calcineurin inhibitors cause afferent arterial vasoconstriction. They stabilize the actinic cytoskeleton of the podocyte. These all lead to reduction of proteinuria. And if you have a study where the outcome is reduction of proteinuria, then the calcineurin inhibitors will come out ahead. But the bottom line is, I don't know whether this does anything good for our patients with lupus nephritis. These are some of the results from the multi-targeted therapy. Again, not a dramatic change between the multi-targeted therapy, including tacrolimus, and the orange arm, which was prednisone and cyclophosphamide. And here's the change in serum creatinine over the period of time. And again, they were comparable, but there was a signal that maybe with the addition of the calcineurin inhibitor, there's less improvement in the serum creatinine because these drugs can affect the kidney function. So as I said, I'm troubled by the voclosporin studies, while they purport to be different from the other calcineurin inhibitors. But again, when you have remission of proteinuria as an outcome variable, then you're going to see the calcineurin inhibitor group do better, because that's what they do, is they reduce the proteinuria for as long as you're using it. Now, to its credit, in this particular voclosporin study, there was more of a decline in anti-DNA antibodies in the CNI group. But again, that has not been shown in so many studies to be predictive of a better kidney response. And in this, they were able to get away with a faster tapering schedule than what is usually used. But again, no difference in GFR over the course of the study with the voclosporin versus the placebo group. And interestingly, there were more deaths in the voclosporin group, especially surprisingly the lower dose voclosporin group compared to the placebo group. So there's that excess of death in the lower dose voclosporin group. So while everyone seems to be very impressed, I'm not really impressed at all with this study. And what about Bulimimab? This is a B-cell BAFF antibody. And I just want to show you, this is from a while ago. And I just want to point out one thing to you, because we'll come back to it. This was a review of the use of Bulimimab in non-renal trials. And you can see in the Bliss 76 study, Bulimimab versus placebo was in favor of Bulimimab. Not in a magnificent way, but you can see that the response was about 40% in the Bulimimab group and 30-something% in the placebo group. So keep those two numbers in mind, 40-something% versus 30-something% in the non-nephritis trials. Now, this was Bulimimab for patients with lupus nephritis. And there's a couple of things about the study I do like. At the urging of the nephrologist, urinary sediment was not considered an endpoint because, as I mentioned before, it can take a long time for this to go away. And unlike the voclosporin trial, they did allow a decent amount of corticosteroid, and there was a 2-year follow-up, which I think is really important, because I think it's really the corticosteroid that's doing most of the heavy lifting in the first 6 months of the trial. So here are the results, and what I have in the red box there is to show you that there was in favor of Bulimimab in this recent trial, except for patients in two groups. One is those with membranous lupus, pure class 5, also those of African ancestry, and also those who were treated more in the European sphere with the so-called Eurolupus trial of lower dose cyclophosphamide for 12 weeks, followed by azathioprine, which again was not significantly better with the addition of Bulimimab. And in a post hoc analysis, so take of this what you will, first of all, what was very interesting is that when they stratified people by baseline proteinuria, so you probably can't see my arrow, but if you can see, it says baseline proteinuria level, low versus high, and high meant anything greater than 3 grams per 24 hours. And what was interesting is if the baseline proteinuria was greater than 3 grams, there was no benefit to the Bulimimab. So was this just the 3-gram business, just a surrogate for membranous? I don't think so, because all the different classes, including the membranous, averaged around 3 grams of protein. So Bulimimab has proven benefit in extra-renal lupus. And in another post hoc analysis of this study by Fury that I just showed you, Bulimimab seemed to increase the time to the first reduction in GFR. Again, like the 3-gram business, this is all post hoc and is only felt to be hypothesis generating. The best news about Bulimimab is there is no signal for harm. So this looks at all the different Bulimimab studies, and the risk ratio is basically 0. And this is fatal infections from lupus with or without Bulimimab. Again, no signal at all. So that doesn't seem to be the problem. But it's not a magic bullet. And I just want to show you the primary endpoint in the renal lupus trial, that it was about 40% something for Bulimimab and 30% for placebo, which is very reminiscent of what I showed you in the non-nephritis trials, 40% or something response with Bulimimab, 30% without Bulimimab. So, as I said, in this trial, there's still a high number of non-responders in both groups. And in the groups who received the Eurolupus regimen, there was no difference between the addition of Bulimimab or not, and those also with African Caribbean descent. So Bulimimab is not a magic bullet. What's the future of it? In my take, the results may be statistically significant for some subgroups, but this is not a slam dunk. This is not really a big hit. Is it going to be used for people with resistant lupus nephritis, those who can't tolerate other forms of immunosuppression, or maybe for non-adherent patients if they can get their medication at a clinic or an infusion center? This was presented by Dr. Michelle Petrie at the American College of Rheumatology very recently, and I just want to show it to you to show that I disagree with so much. So first of all, I don't see any advantage at the get-go for using Bulimimab or a calcineurin inhibitor, and even at 3 to 6 months, it may be too quick to say that there hasn't been a big enough change. And I would not consider at that point adding in a calcineurin inhibitor. And I think it's too quick to say, well, switch to cyclophosphamide after 3 months, for example. There have been changes in the KDIGO guidelines, aside from what I showed you in terms of resistance and non-adherence. So on the top there are the 2012 guidelines, and what's circled at the bottom are the 2021 guidelines. And just to show you that since then, they've taken out the daily oral cyclophosphamide regimen. They've taken out the NIH type regimen also, leaving a choice of MMF and a Lupus 500 milligrams every 2 weeks kind of a regimen. And that's what we have. Now, something else that I want to mention is I'm not happy with this recommendation that if they have class 4 lupus nephritis, they should be given pulse methylprednisolone. I think that's inappropriate. Let me show you why. Here's 2 different patients with class 4 lupus nephritis. Patient 1 is noted to have some blood and protein in the urine, but was feeling all right, and waits a month to see you for a consultation, and you decide that the patient needs a kidney biopsy, and they wait another week, and they get their biopsy, and then you wait another week and get back the report, and there are some foci of endocapillary proliferation, but good preservation of kidney function, a few endothelial deposits, and is signed out as class 4. So after all these weeks, they have this. Does this mean because you get back this number class 4 that you have to bring them into the clinic or the hospital and give them pulse solumedrol? It makes no sense to me at all. Compare patient 1 with patient 2, also with class 4 lupus nephritis, who's admitted to the hospital with rapidly rising creatinine. They're sick, they're pancytopenic, they have a kidney biopsy that shows diffuse endocapillary proliferation, maybe some crescents, massive immunoglobulin deposits, and they have class 4 lupus nephritis. So not all class 4 nephritis is the same. And I wouldn't dream of bringing in the first patient for pulse corticosteroid, whereas I think it would be a very appropriate therapy for the second patient. So I don't think you can make these kinds of blanket recommendations. So if I had to reduce my talk to one slide, this is what it would be. Lupus nephritis not responding to therapy. The first question is, have you waited long enough? Don't be too impatient. This is not minimal lesion disease. This is not something that gets better in a few weeks. If you have waited long enough, is the patient taking their medicine? And if the answer is no, well, that's why they're not getting better. If the answer is yes, there's 2 sub-possibilities. They say yes, but they really aren't. And that is, I think, way more common than what we think. And of course, if they say they are, but they aren't, that's why they're not getting better. Finally, they may say, yes, they are, and they really are. And in that case, I think that they have very resistant disease. And the fact is some people just have that. And as Galen said, there's nothing that really treats really bad disease. And with that, I'll thank you for your attention, and I'm happy to take any questions. Is there anyone there?
Bargman. Thank you so much, Professor Bargman, for the wonderful talk. The forum is open for question and answer session, and I would like to invite our chairperson, Professor Ijaz Ahmed, to take over the session.
Thank you.
Assalamu alaikum, Dr. Professor Ijaz. Can you hear me? So we have a question from Dr. Ashar Alam. What is the incidence of avascular necrosis in patient on long-term steroids in your part of the world?
I don't know the answer to that.
But do you see it commonly, or?
Yes. That's another source of fascination to me, because some patients truly take corticosteroids for the longest time and never get this. And I've seen patients get avascular necrosis of the hip or the knee sometimes within like a month of taking high-dose corticosteroid. So there's marked variation, but I couldn't give you an overall percent.
Okay, thank you. The other question is, we have a short comment from Dr. Salman. They ask, "Hey, what a nice presentation, Dr. Bargman." And then he's asking, "Okay, would like to know, okay, do you think the same thing is happening with cyclophosphamide from rituximab, as was happened to azathioprine from the cyclophosphamide in the past?"
Are you saying that there's like a trend for more treatment with rituximab and less with cyclophosphamide?
Sorry,
Can
you
you
repeat?
Can you explain the question?
Do you think that the same thing is happening with cyclophosphamide from rituximab, as it happened to azathioprine from cyclophosphamide, and it's the trend switched from azathioprine to cyclophosphamide?
Right. Well, people love the idea of rituximab. It's probably one of the most used drugs without any rigid underlying proof. But people are just always convinced when nothing else is working, quote unquote, that they need to give rituximab. And I think in some patients it does work, but as I said, it's like really unproven. In my part of the world, as I'm sure in yours, it is ridiculously expensive. And unless the patient has private insurance coverage, or you can make application to the government to get it covered, and that can be quite difficult to do. So it's not an easily accessible drug. So I don't see it suddenly becoming the standard of therapy. I think most people overall are happy with mycophenolate or myfortic, and I don't see it grading into a use of rituximab over time, especially without the proof that we need. Does that answer your question?
Dr. Ejaz, can you hear us? Us? Sir, can you hear us? I think we have connectivity issue with Professor Dr. Ejaz.
Okay.
So we can move to the next question. So there is another question: how long we need to give anticoagulation in patient with the secondary APLA, antiphospholipid?
Oh, I think it depends on how their thrombotic complications, but we have a lot of patients with secondary APLA who are on lifelong anticoagulation. I say the majority of them. If they've come to attention by a clotting event, our coagulation people tend to put them on lifelong.
And if the lupus nephritis is in remission, even then we need to continue it lifelong?
I'm sorry, is this the anticoagulation in people's secondary APLA? Or
In
just
secondary associated with lupus?
I don't know. We have an APLA clinic where they make these kinds of decisions, so I really can't comment. I'll just tell you that I share a lot of my lupus nephritis patients with the APLA clinic, and it seems like they are on forever anticoagulation.
Question. What is your experience with the TMA associated with lupus nephritis, secondary microangiopathy, thrombotic microangiopathy?
Thank you for that. Thank heaven it's not very common, because it can be an awful thing to treat. And we tend to treat with corticosteroids and, of course, anticoagulation. And I can't comment so much, honestly, about renal thrombotic microangiopathy, because these patients, although you could say it's an indication for kidney biopsy, to distinguish between thrombotic microangiopathy and classic immune complex related lupus nephritis. In reality, these patients are often presenting with a platelet count of 10,000, and it makes a kidney biopsy high risk. So we tend not to do a kidney biopsy. So I can assume or not assume that what's going on in the kidneys is thrombotic microangiopathy secondary to APLA. But in most cases, this is only my best guess because we don't biopsy this because the biopsy is probably more high risk than anything. And just as a side note, don't think you can hold the anticoagulation for a few days in someone with APLA to do a kidney biopsy and then restart the anticoagulation, because these people can bleed and they can bleed late and it can be a really big mess. So as I said, we tend to shy away from kidney biopsy in patients with APLA who are on anticoagulation.
So there is another question. My question, how long do you wait to label it resistant lupus nephritis and suggest repeat renal biopsy for class switch?
So let me take the second question first. A class switch depends on the clinical context. If it's just that the creatinine is staying up, then I'd say I don't see why do a kidney biopsy unless you're worried that this is just chronicity. If it's going to switch from, let's say, a proliferative type of GN to a pure membranous, which I've seen before, it presents itself clinically. Someone suddenly becomes heavily nephrotic, peripheral edema, things like that. That's what we see in a clinically obvious class switch. So we don't rush to do a repeat kidney biopsy just on the basis of a class switch. Now, in terms of how long do you wait to truly call it resistant? Again, that's the question. And I'd say at least 6 months. You should see, as I mentioned before, some stuff going in the right direction, like the hemoglobin should be coming up. If you're lucky, the albumin should be drifting up a little bit. The complements should be coming up a little bit. And if that's all going in the right direction, I think you just have to sit tight and continue with a very slow taper of corticosteroid, but just comfort yourself that things are going in the right direction. So I'd say sort of a 6 month point is the point to sit back and reevaluate, or maybe at 3 months too, but to make sure that things are going in the right direction, not necessarily to have normalized.
So, and the other question is, if there is no need of pulse therapy in proliferative lesion with normal renal function, as you stated in your presentation, then what are the indication nowadays for pulse therapy in lupus nephritis?
Yeah, well, for lupus nephritis, I think just the second scenario I gave you of someone with a rapidly rising creatinine, blood and protein in the urine, and all positive serology. I don't even think you need a kidney biopsy. And in fact, it would be a high-risk kidney biopsy because these patients often at the same time as this kind of dramatic presentation have thrombocytopenia. More often than not, they're hypertensive. So it's a high-risk kidney biopsy. So if they present with that second box that I showed you, the second box, patient 2 there, creatinine 88, 160, 220. In this case, they did have a biopsy with very, very active disease, then that may be an indication for pulse corticosteroid. But like I said, patient 1 would also be classified as class 4 lupus nephritis, but it's a whole different clinical context. So that's the problem with these KDIGO recommendations, is they don't take into account the nuance of the presentation.
And if a patient with lupus nephritis is not tolerating a steroid, what is the best alternative you consider? best alternative drug.
And the patient is what? Not tolerating steroid? Is that what you said?
Steroids, yes, not
Yeah.
tolerating steroids.
Yeah, that's really tough. The steroid-free protocols for lupus have been tried. For example, this is one of the indications for Rituximab. Although remember, this is not steroid-free. When people go onto a Rituximab protocol, they get 2 pulses of corticosteroid with their pulses of Rituximab. But it's true, and this is why at the outset you have to emphasize to the patient about the side effects of the corticosteroid so that they're prepared for it and they don't just suddenly develop some acne and say, well, I'm stopping this medicine. They have to be educated about the seriousness of the disease so that perhaps they're more motivated to take their medications, including the corticosteroid. But yeah, it's a big problem, and I really wish we could have a corticosteroid without the corticosteroid side effects. Any other questions?
Yes, can you hear me?
Yes.
So the other question is, if a patient became end-stage renal disease and became chronic hemodialysis dependent patient, maintenance hemodialysis dependent patient, and he had the primary disease lupus nephritis with associated APLA, then how long would he be needing warfarin, and how long, or any other anticoagulation?
Yeah. Again, I'm not a big APLA expert, but if this person needed anticoagulation before they started on dialysis because of thrombotic events, I would think that they definitely need to continue on it, both for the vascular access and also for the rest of their body. So my best guess is that these people, again, even though on dialysis, would need lifelong anticoagulation. As we know, our dialysis patients who receive anticoagulation also have a higher incidence of bleeding compared to non-dialysis patients. But again, I think on the risk benefit overall, if they've had major thrombotic events, I suspect that they would be kept on anticoagulation during the dialytic period.
So next question is, so any other questions from audience? So with this, we
Are you there?
can you give us 1 minute?
Sure.
Sorry for the inconvenience. So the next question is, how do you treat severe lupus first time presentation? Severe lupus nephritis at
Yes.
first presentation.
Well, let's say it's more like patient 2 that's up here. I hope it's still up on your screen. With severe lupus nephritis. We'll treat with either, again, depending on the amount of extrarenal disease, but either milligram per kilogram body weight of prednisone, or else, again, if the creatinine's going up really fast, or if there's pulmonary infiltrates or evidence of cerebritis, we will give pulse corticosteroid. And I'm not in a big rush. It's really going to be the high dose corticosteroid that's going to put out the fire of the original presentation or flare. Then when the dust has settled, then you can add a second agent, which is usually MMF for us as the second agent. And again, there's no rush to get up to induction doses right away. And the last thing you want to do is make the patient nauseated. So we might start with something akin to 500 milligrams twice a day of MMF to start with, and then gradually titrate it up. But the most important point is to give the high dose corticosteroid at the get-go, and then you can worry about all the other stuff after it. Does that answer the question?
And how is your experience with oral cyclophosphamide?
We don't use that much daily oral cyclophosphamide, and as I showed you, it fell off the KDIGO recommendations. Having said that, I don't like using intravenous cyclophosphamide in patients that have AKI, because you can lower the dose of cyclophosphamide, but once you've given it, you've got to live with the results. And some of the people can end up with a consequent leukopenia from the cyclophosphamide, which puts them at risk for super infection. So I'm not a big fan of high-dose pulse cyclophosphamide in the context of decreased GFR. And in that case, I have used daily oral cyclophosphamide. But as and that way you can watch the white count, make sure that it's not going too low. And if it looks like it is going too low, you can hold the daily oral cyclophosphamide for a few days and then start it back again. But again, if the patient's going to be adherent to daily oral therapy, we tend to use MMF instead of the cyclophosphamide. It's freely available in Pakistan, isn't it?
It is easily available in Pakistan.
Yeah.
Oral cyclophosphamide, yes.
No, MMF.
MMF is also easily available, and we frequently use it. The next question is about the dosage and duration of rituximab. How do you use the rituximab? What dosage do you usually give, and till how long?
Again, I don't have a lot of experience with rituximab because it's very hard to get. As I said, either the patient has private insurance, which is rare, or you have to make a plea to the government to cover it. But when we do, we give out 1 gram, usually separated by 2 weeks, and then wait about a few months. Because again, this is something that takes a few months to work. And again, it's hard to know if it works. If you're struggling along with daily oral prednisone and MMF, and you're either impatient or it appears that the patient isn't getting better, and you arrange and you give rituximab, and then 3 months later the patient's better, would they have been better anyway, or was it the rituximab that helped to make it better? And I don't have enough experience to be convinced either way. So I think it has to be with the first go around that you have to wait several months and see if it's your impression that it helped to bring the disease under control. Now, sometimes the rheumatologist will use rituximab in other aspects of lupus, such as autoimmune anemia, things like that, and that's very legitimate too. But I'm talking about treatment from the nephritis viewpoint.
So we have no other questions. Any other questions from the audience? So with this, we are going to conclude this session. Thank you so much, Professor Joanne Bargman.
Thank you. Thank you for inviting me.
Wait, we have another question.
Yes.
Okay. So it is not. So the question is, so when can you advise them to conceive A
That
female
is,
patient.
that's a giant
You're talking
question.
on.
Just to make an answer, this it's going to be superficial, uh, but they should be with inactive lupus off any potential phytotoxic medications such as MMF or ACE inhibitors or ARBs. They should be with clinically inactive disease for a year before considering conception. That's about the simplest I can put it.
Hmm. So, okay. So with this, we have no more questions. Thank you so much, Professor Bargman. It was a wonderful talk and very learning as too.
Okay.
So thank
Thank you.
you. So we are going to take 10 minutes break now, and we will then go for our second talk, which is yet another interesting talk on ABO incompatible renal transplant. Thank you. ये क्यों नहीं चलता है? Good morning, Assalamu alaikum. I'm again Dr. Javeria Chughtai with you with the second talk of the today's nephrology scientific session. So again, we have two panelists. This session is being chaired by Dr. Syed Fazal Akhtar from Sindh Institute of Urology and Transplantation, Karachi, and this is co-chaired by Professor Dr. Hafiz Ejaz Ahmed from Pakistan Kidney and Liver Institute and Research Center. So our next talk is by Dr. Jeffrey Zaltzman. Dr. Jeffrey Zaltzman serves as the director of renal transplant program since 2000. He was actively involved with Kidney Foundation of Canada at both provincial and national levels. He has research interest in renal transplant and transplant ethics. To date, he has over 80 peer-reviewed publications. He will be presenting his talk in ICON 2022 today on kidney transplant against ABO incompatibility and its current protocols without and outcomes.
Thank you very much. I'm sorry for the technical problems. I hope everyone can hear me. Can people hear me?
Yes, we can hear you, Dr. Zaltzman.
Yeah.
Good
Okay.
morning.
Good morning. Good morning, everybody. I hope it's a good conference for you. I know it's already early evening. I'm sorry. I could not access on my Mac computer, so I had to send the file to my other computer. But I think we're working. So let's start. So I have no conflicts. And what I want to do today, we're going to talk about ABO, incompatible living transplantation. I just want to give you a brief summary of what we do nationally in Canada, because we have a successful pair donation system. Then we'll talk about the
Sorry
world
for the
experience.
interruption, Dr. Zaltzman. Can
Yeah,
you keep it on slide share full screen? Make it full screen?
I'm sorry, is it not? You're not seeing the
Uh,
slides?
we can see it, but please slide share. Click on slide share to make it full screen.
Click on slide share.
Press
Yeah,
F5.
F5. All right. Does that help? What are you seeing? Are you not seeing the slide?
No, it's okay. Please continue.
Okay. So I want to talk a little bit about blood group incompatible living transplant and then our experience at St. Michael's Hospital. So this is Toronto, where some of you have trained. And this is St. Michael's Hospital where I work. We've just put on a brand new building, which we had to open during COVID. It's still not completely opened. And this was Toronto 3 days ago. We had a pretty big snowstorm. So people were digging out and the city came to a standstill, but not so important for today's talk, but it kept a lot of people very busy. So when we look about why living donors have been excluded, and this is work going back now 15, 16 years, one can see that that either because of a positive cross match or incompatible blood type excludes almost half of any potential living donors. So we need a way to overcome these barriers, which up until recently um, excluded many wanting and potential donors. So in Canada, we have a pair donation system that involves every program across the country. And Canada is a very big country geographically, but not very big in terms of population. And it's been in existence. This has been in existence now since 2008. And I won't go through all the details, but very simply, I think you know the principles behind this. If you have a donor recipient pair, who are incompatible, let's just say by blood type, the donor is A and the recipient is B, then you could match those people to another pair where the donor is B and the recipient is A and do a transplant. And this is a simple paired exchange. But in Canada, we have a program that matches both blood group incompatible and HLA incompatible donor recipients who are accepted. And we have we've worked very hard to enhance our HLA and our identification of HLA antibody, and a very sophisticated program that allows us for optimal matching that we do. So this is just some data. We match by cross match. We match for HLA class 1 and class 2. We look at all the HLA antibodies. We want to say what's acceptable, what's not acceptable, and then we do these matches. And basically, we match around 100 to 130 pairs with each cycle. That's about a 33% match rate. And the computer spits out a lot of potential matches, but we want to optimize the most transplants looking at a bunch of criteria: how long people have waited, their sensitization, their ability to find a kidney, and you get these nodes and points, which is behind the scenes. But basically, just to show you, this is actually a year old now, and we've done now well over 1,000 transplants. You could see that 73 of these.
Dr. Zaltzman,
Yes,
are you changing your slides?
yes. Are you
But we cannot see it. We are still on the first slide, ABU Incompatible, the title slide.
really? You're still on this slide, huh? Where? What slide are you on? Which one does it look like?
Sorry,
Which
can you
slide
repeat?
Which slide are you seeing?
We are on first slide, title slide.
Just the title slide, really? Oh my God! Oh, I've changed a lot of them.
Okay. Have you on your slideshow?
Yep. Yeah, it's slideshow.
Yes. Now it's now it's moving.
Okay, hang on a second. Is it moving now?
Yes, it's moving now.
Okay.
Can you change again? And switch to another slide, please.
I've been switching. Okay, so it's not moving. Okay, so slideshow is not working.
Yes, now it's working.
Yeah.
Thank you.
But this is not slideshow. Is it working now?
Yes, it's working now.
Okay, so you're gonna have to look at it this way because the slideshow is not moving the slides. Anyway, I'll just repeat what I said. I said that we basically, I'll skip the snowstorm. Living donors are excluded by blood type or HLA, and we have a national system that we've had in place since 2008 where we have paired donation. And ideally, the simplest one is an incompatible blood type A and B donor, let's say, who we match with an A recipient and a B donor from another pair. And that's the simplest paired exchange you can do. I'll skip this slide. But in our system, we put people into the system about 100 pairs every 3 or 4 months, and they're matched based on HLA compatibility, virtual cross matching to be done. They're matched on blood typing, willingness to travel, and then we have a priority based on how long they've been on dialysis and so on and so forth. So what we've done, and this is just through October of 2020, we have now done over 1,000 transplants through our national paired donation system. 73 were from a simple pair donation, which is one pair with another pair. 215 were from what we call closed change. That involves 3 pairs of donor recipients. And 469 were what we call domino, which is a NDAD. The NDAD is a altruistic donor who does not have a recipient with him or her. And that person graciously donates, and you set off a chain of events. The last kidney in that chain, which could be up to 6 or 7 transplants long, goes to the wait list. So as of the end of December of this year, we've done over 1,000 transplants. So this has helped us deal with blood group incompatible and HLA incompatible. So if we focus back to just blood group incompatible transplants, it's been done for many, many years. In Japan, where there was no brain death laws up until recently, they had to use a lot of blood group incompatible living donor recipient pairs. And these protocols were quite extensive, including lots of immunosuppression, often having to remove the spleen of the recipient. And now most centers who do this are using a combination of plasma exchange, IVIG, and Rituximab, and the results are fairly comparable. So historically, the success was poor, only about a 40% graft survival back in the 50s. But in the early 80s and mid 80s, we were getting better survival. And the blood group A2 donors, which express less A antigen, had even better success. But Tanabe in Japan began using cyclosporin, azathioprine, and splenectomy, and he improved graft survival to almost about 80% at 1 year. And in Japan, about 30% of transplants are blood group incompatible. And then the group out of Montgomery's group out of Baltimore, using drugs like using plasma exchange and rituximab and other things, were able to get graft survival rates that were pretty much similar to those of blood group compatible. So in the modern era of blood group incompatible transplants, splenectomy is no longer utilized. It's pretty much gone by the wayside. The principles to ensure that a transplant from a living donor whose blood group incompatible with their recipient is a few of them. First of all, we have to reduce the antibody production. We don't want to make any more blood group antibody. And remember that the blood group antibodies, in addition to being on the blood cells, are also on the vascular endothelium of the kidney. Then we've got to deplete the pre-existing antibody. And you could do that in three ways: plasma exchange, double filtration plasma exchange filtration, which is not used that often. And what we use is a specific column to absorb the antibody from the recipient's plasma to reduce the antibody level. There may be some immune modulation done, which we do sometimes, and of course immunosuppression, and then surveillance. And interestingly enough, these patients only need to be strongly watched for about 2 weeks post-transplant. Unlike HLA, the antibodies become very, very unimportant after about 2 weeks. So to reduce antibody production, in the old days, that was splenectomy. Now we use Rituximab, which, as you know, is a monoclonal antibody that inhibits the CD20 of B cells. And when we give that a month before our transplant to reduce antibody production before the transplant. To deplete antibody, there are three ways of getting rid of the antibody. So the recipients require a central line, or they could use their dialysis access. Plasma exchange is the least costly. It's readily available. It reduces about 20% of antibodies per each pass, and you need multiple sessions, and you can't use antibody titers that are very, very, very high. And we'll talk about those in a second. And you need to use either plasma or albumin, and there's a risk of depletion of clotting factors. Double filtration is very costly. It's not easily available, but it gets a little bit more antibody reduction. I won't say much about this because it's not used very often. And what we use at St. Michael's is specific immunoabsorption with a column that has an antigen that binds to the antibody in the recipient. It's expensive. Each session can reduce about 50% of the antibody titers. You can get away with fewer sessions, and you can plan your transplant very quickly. And you can get rid of titers as high as 1 in 1,056. The higher this number, the higher the level of the antibody against the blood type in the recipient. So I'll show you some data on this shortly. Sometimes we need to immunomodulate, which means intravenous immunoglobulin, to block the monoclonal FC receptor or the monoclonal phagocyte. And this is used. We use this in our program only when we have very, very high levels of antibody titer. For the most part, we don't use it. And then all recipients need immunosuppression. And in our center, we use the exact same immunosuppression for compatible transplants, but we start it a week before. So they all go on tacrolimus, steroids, and in our center, we're using mycophenolic mofetil. Compared to regular living transplants, they get this a week before. And then in terms of induction, you can use either an anti-CD25, which is what we use, basiliximab, or some centers choose to use thymoglobulin, but we just use the lower burden induction agent, basiliximab. And then you have to follow their antibodies after the transplant, because if they rise again, there's a risk of an accelerated rejection, and we have to do additional treatment. But after 2 weeks or 14 days, one can stop. The question is why can one stop? Why are these grafts accommodated after 2 weeks? And it's not really clear. It may be that the antibody quality changes itself. It may be that you shift from an IgG1 to an IgG2, which seems to be less of a problem. And there may be decreased apoptosis. And this is all work, but none of this is actually proven. And this is a very busy slide, but I'll just show you there have been many, many protocols since 2011. The tied-in one uses the specific antibody depletion immunoabsorption column, and that's the one that we use as well. And here's a few more, but there's been many programs doing this. Now, the main column is made by the company called Glycorex, and this is called Glycosorb. It's a very expensive column, and in it is these antigen beads that bind. In the case of this one, if it's an A1, it'll bind A antibody from the recipient. There's also a B1, so you can bind B antibody. So let's say your donor is blood group B and your recipient is O. You would use a B column, and the blood going through this, the plasma would be bound, and the reduction of the antibody level would occur. So the way this is done is basically through regular plasma exchange machine. The plasma gets separated, the blood returns back to the patient, and the plasma, instead of being exchanged, let's say for albumin or for plasma, it's not exchanged. The plasma goes back to the patient, but it passes through this column. And as it passes through the column, the antibodies get stuck to it like a sponge. So the antibody levels that come back to the patient are far less than they were before going in. And that's how we do our protocol at St. Michael's. And here's a patient on a machine. And you can see this is a regular plasma exchange machine. This is the plasma that's going to be treated. And this is the little column in tape here. It's so tiny. But it's regular plasma exchange machine, but the patient gets his own plasma back that's been depleted of antibodies. And here is the column again attached to the plasma machine. This is the plasma going in and the plasma going back to the patient, deplete of antibody. So the protocol that Tiden used from Sweden was to give Rituximab at 30 days prior to transplant, then put them on, at the time he was using tacrolimus Prograf, Cellcept, and prednisone for 1 week prior to transplant. Then about a week prior to transplant, they would do the Glycosorb columns, 1, 2, 3, 4. Depending on how high the titers were, you have to do more columns. They would give IVIG, which we do not give. And then if you needed, you could give more columns post-transplant if there was a rebound. Thankfully, that didn't happen. So this graph shows you that the titer in this patient was 1 in 64, and it came down to less than 1 in 2 and remained so, although they didn't have to do any additional. So the protocol at St. Michael's is we look at blood group A donors to O recipients, A to B recipients, B to O, B to A, AB to A, and AB to B. I'll tell you the AB donors are important because they're hard to match in a national system, because AB donors can go to any blood type, can only go to AB recipients. So the AB, if you have an AB donor, we almost never consider them for our national pair donation system. And our maximum titer that we accept in our program is 1 in 512. Preoperatively, as I mentioned, they get Rituximab 4 weeks before transplant. They begin standard immunosuppressive therapy with tacrolimus. We use Advograph once a day, Myfortic, and prednisone 1 week before transplant. They get their immunoabsorption treatment started 1 week before transplant, and typically we want to obtain a titer of 1 in 4 or less. Okay, usually using 2 plasma volumes for every session that we do. If the target's not achieved, we sometimes have to postpone the transplant for 1 week and do more sessions. As I mentioned, 2 sessions are used, but sometimes we'll use 3. And we can reduce the IG by 2 to 3 fold with each step. We don't use IVIG unless the titers are very high. So we use it only when the titers of the anti-A or anti-B are 1 in 128 or greater. Post-operatively, they get basiliximab preoperatively. They maintain their Avograph, their mycophenolic mofetil, and prednisone in our usual tapering fashion. And then we monitor their anti-A or anti-B antibodies every day for the first week, and then on days 8, 10, 12, and 14, and then we stop. And we will only do another treatment if the levels exceed 1 in 8, so 1 in 16 or higher, and if they exceed 1 in 16 in the second week. And then we don't stop monitoring. We stop monitoring. So this was our first one. And I'm going to give you the results of our first 24 patients. We actually published this last year. So we had 24 blood group incompatible patients. 87% were male. They were 51 years of age. And we had 10 who were blood A to O, 10 A to B, 3 B to A, 7 B to O. And you can see a couple that were AB donors giving to their A and B recipients. We always offer people the national paired exchange system first. And sometimes we allow them to do a few match runs, but if they don't match and they want to come back, we can do this for them right away. But these two pairs, we don't even offer them. We say you're not going to ever be matched, so we do this right away. And then our titers in our started at 1 in 4, which is actually our target, to as high as 1 in 512. And the amount of treatments range from 1 to 5 with a mean of about 2. And 3 out of 25 patients, or 12%, needed a treatment after transplant. So not a high amount. What we learned very quickly was that the higher the titers, the higher the more treatments. And when we got rid of the one with the highest titer, the correlation was even higher. So we know starting off, when we measure the titer of our recipient, how many treatments we have to plan for before we actually do the transplant. And our results are as following. Every patient survived. We had 96% graft survival, and this is out to 5 years now. This is a 5-year graft survival. One graft was lost after successful desensitization, but there was a technical loss at the time of transplant. One patient actually stopped and was retransplanted later. We've had no rejections, and our allograft function has been pretty good, with a mean creatinine at 5 years of about 0.97 mg per deciliter, or 85 micromole per liter. So in summary, blood group incompatible transplants is no longer a barrier. You have options of kidney pair donation, and of course, you can also do desensitization techniques. And in the modern era, if things are done well, blood group incompatible transplant is just as successful as blood group compatible living donor. The columns that we use are expensive, but they are most efficacious, and we've had a good experience with them. And I just want to acknowledge some of my colleagues that have worked with me. So I'll stop there. I know I started late, but hopefully there's a chance for a few questions. That's the end.
So I'm handing over this session now to our chair and co-chair, Professor Dr. Syed Fazal Akhtar and Professor Dr. Hafiz Ijaz. Assalamu alaikum. Sir, can you both hear me?
Yes, we can.
It's going to be 15.
Professor Dr. Fazal, can you hear me?
Yes, I can hear you loud and clear.
Yes. Thank you. So,
is there any question from any audience which I can ask to the Professor Zaltzman?
Yes, please go ahead.
No, I mean, let me ask the first question. How much in the Canadian dollar one transplant costs?
In Canadian dollar, without using the columns, so if we're just talking about a regular transplant, it probably ends up being about 40, everything with the donor, everything about $40,000 Canadian.
40,000, yeah, okay.
Yeah.
And but before using this column, do you used to use the plasmapheresis?
No, we've never done plasmapheresis for this. When we started our incompatible group back in their first one here, which was in 2011, we went to learn about this technique from our colleagues in Sweden. So we saw what they were doing. We saw the presentations, the publications. So we decided that we were going to be using this technique. So we never did ABO incompatible before using the column. Other groups have, but we've only done the column.
Is there any question from any audience? I can see any question.
Any question from audience? They can put down their question in the question answer box.
I will just say that the columns are expensive, and they make them. That's why they haven't been widely adopted. They are not yet approved in the United States, by the way, only in Canada. So the Americans have not had the opportunity to use these columns at this point in time. They're approved in Canada, in Sweden, in Germany, Australia, I think in the UK, but not every country.
Not every country. Somebody asked me the question that are we going to use the Incompatible transplant in Pakistan? I mean, what we have got experience with the transplanting the highly sensitized patient. I think the transplantation is done probably the same way as the Incompatible with the transplantation. But so far, we haven't started with the Incompatible transplantation. And with the highly sensitized patient, I mean, if we use, say, the plasmapheresis. But I mean, as you described, I mean, your results are remarkably good. I mean, I will say that 5 year post-transplant, the average serum creatinine was less than 1 milligram. That is remarkably good. So once the thing settled down, that I think it looked like that the glycosol, it does a remarkable job as compared to the plasmapheresis.
Yes, so I would make the point that the blood group incompatible, although it's certainly an incompatibility, is very different than HLA sensitization, because the problem with HLA sensitization is that even if you remove antibody and allow people to get transplanted, although there are some newer agents coming out now that look promising, it's always a concern that the HLA antibody comes back and leads to either an acute rejection or chronic antibody-mediated rejection. That's not the case for blood group. So blood group is much more, it's a much more easier incompatibility to deal with than HLA for sure. And that's why when we have an HLA incompatible living donor pair, they go into our national paired exchange system, where we look for acceptable matching or with our donor recipients.
We have another question from Professor Dr. Salman Imtiaz. Do you see any difference in the rate of infection in ABO incompatible transplant as compared to ABO compatible?
Yeah, it's a good question. In fact, we have not seen any differences. In fairness, the only real additional immunosuppression that they get is the Rituximab, and that's a month before, because we use the exact same immunosuppressive agent, and the glycosorb column itself does not have any impact on making someone more susceptible to infection, because it's really specific only for the blood group antibodies and nothing else. So there's no other immunoglobulins removed from the plasma, nothing, So, with plasma exchange, for example, if you remove the plasma and you remove antibody that's important for infection, and you replace that with albumin, there are higher risks of infection with plasma exchange. There's no doubt about it. So with this column, they get their own plasma back, and you're not removing anything from the plasma except the blood group incompatible antibodies. So the answer is no, we have not seen any additional infections. As I mentioned, the only additional immunosuppression they get is the Rituximab 1 month before, and that seems to have not been a problem thus far for us.
And do you use the same prophylactic antibiotic?
Yes. Everybody gets prophylaxis against PJP, so they usually get trimethoprim sulfa. And if it's a CMV mismatch, they'll get valganciclovir, and that's all they get. Yeah. but nothing changes.
And do you do any protocol renal graft biopsy
We do
for
not. No.
surveillance?
No, we do not. No protocol biopsies.
So, Dr. Hafiz Ejaz,
Yeah,
any
Dr.
comments from you?
Zaltzman, I have a little diversion for my question. Since ABO incompatible transplantation is one of the opportunity in our country, another important, I think, opportunity could be pair donation. Do you have
Yes.
any experience in your setup about pair donations, which I think many of our donors are get lost because they are not compatible for their particular recipient. So
Yes.
pair donation could add to our armamentarium, and we
Yes.
would like to have your experience, please.
Yes. So I mentioned this. Maybe I went through it a bit quickly when the slides were not shown, but we do have a national pair donation system that's been in place since 2008. Okay, and it is very, very successful. And this is just showing you the data up until last October. But as I said, we've done 1,000 transplants in Canada through pair donation system. But it involves HLA labs that speak the same language. They have to be able to make sure that an antibody in one center is the same as another, and characterize the donor HLA antigens exactly the same way. So before we did this, all the labs in the country, and there was about 14 of them, had to get together and basically everybody had to come up with the same standards. And then our Canadian Blood Services, which runs the blood supply in Canada, they're the ones who actually help manage this. They're the group that actually works with us. They work with all the transplant centers, and there's a kidney working group and a liver working group. And basically, what happens is that all the transplant centers know about this, and they've been doing this. And when they find a donor and recipient pair, let's say a pair here who's just blood group incompatible. So this donor is A, and the recipient is let's say B. Once the donor and recipient are ready to go, but they're not compatible, they put in all their data, their blood types, their HLA data, their antibodies in terms of the recipient, where they live, how long they've been on dialysis, their sensitization, all that, and all that goes into a computer system that matches people virtually. And it's done quite it's a quite system. You can see there's multiple matches that could come up for any pair, but what they do is they optimize the amount of matches that occur, so that what happens is that you can then determine a match between a donor and recipient who may live in very, very different parts of the country, and then they're reviewed, and then you have to plan the operation. So it takes a lot of work. It's a lot of effort, but it's really this computer system that we would be happy to share with anybody, that allows us to do the matching virtually. And it's worked quite well. As I said, over 1,000 to date so far this way.
I mean, what we can say that I mean, at the Sindh Institute of Urology and Transplantation, we did start the pair donation program, and we did about 6 pairs of transplantation. But for the last 2 years, because of the COVID, I think it has become dormant. And once I think the COVID is settles down, then perhaps we are going to restart it again.
Yes. Were you doing it just by looking at pairs and then checking one pair off against another? There was another question, was why ABO incompatible transplant not approved by the HOTA in Pakistan yet. I think what it is, the HOTA is a regional. Regionals mean in different provinces, they might have different rules. I mean, it might be that the HOTA in Punjab, they don't allow the ABO incompatible transplantation. But if one unit is ready,
they can approach the HOTA and they can say that they want to start the program. They have to just show the data, that how you are going to start the program, what should be the protocol, and then the HOTA will allow it. I mean, I'm talking about the HOTA in Sindh, in Sindh, that they will probably allow it. But I can't say about the HOTA in Punjab or HOTA in KPK. So I can't tell anything about them.
I
There
have
is
no
another question
information
from.
about Punjab. I think my view is the same, that if we approach HOTA with all the facts and our program, I think there would not be any problem in that.
There is a question for Dr. Fazal. How was the outcome of your paired exchange renal transplant patient?
I mean, it was very good. It was. I mean, say as good as the other transplant program, because I mean, what we were doing is that, I mean, because we started the program, so we were very cautious, or I will say that we were very picky, that they have to have a good antigen, the antigen match, at least 3 or 4 antigen match, and that's what it worked very well. Is there any more question from any audience? I mean, we would like to hear from you.
Dr. Mubarak has a question. Do you perform protocol biopsies in this patient? So we have already asked this question. And there is a comment from Dr. Farhana Amanullah. She agrees that 5-year outcomes are excellent in ABO incompatible transplant group.
Sure.
Any other question from the audience?
The thing that I will say with this, like the new technology, the glycosome technology, I mean, I think the amount of immunosuppression, that what we are really scared of, is because the mortality in our region is because of the infection, not from the cardiovascular. So we do not want to over immunosuppress our patient. But what I have observed from your presentation, that the only additional thing, the additional immunosuppression they get is the Rituximab.
Correct.
And even for as induction, you are using as anti-CD25 antibody, not the ATG. I mean, that is very remarkable. And you're not using the IVIG, because the cost of the IVIG is very high.
Right. Yes, so you're absolutely right. So we're not a big ATG center anyway. We don't use a lot of ATG in most of our patients. So we didn't think we had to change for ATG for these patients. There was no real compelling evidence, and the initial work from the Swedish group also did not use ATG. They used Basiliximab. So since that was our standard of care, we didn't want to change it, at least for this. So in Canada, half the centers use ATG for most patients. The other half use Basiliximab. So we're more Basiliximab for most patients, including these.
And do you repeat the dose of Rituximab after transplant, after like some?
Yeah, no, we don't actually. No, just the one dose. Yeah, just the one dose. The real downside to this technology, because it works well, is the cost. The columns are much more expensive than if you were using regular plasma exchange, which is available. there's a cost to these for sure. We've been fortunate because we're the only place doing this that they've given us a bit of a break on the costing of it, but it is expensive technology.
And usually we do not see resurgence of the antibodies.
Not usually. Sometimes we do, as I mentioned, in about 24 cases, we saw it 3 times, in which case we had to give an extra treatment, but for the most part we don't. So there's
there is a question.
Yeah.
Have you
Yeah.
ever done any ABO incompatible transplant in
Yes.
child recipients?
Yes. So we don't have a pediatric program, but we have one in Toronto. Ironically, at Hospital for Sick Children in Toronto, they used to do ABO incompatible heart transplants for pediatric because it's hard to get a heart, with some mixed experience. And since we had the columns, we've given them to our colleagues up the road for heart transplants with very good success. So they've done about 3 or 4. I'm not sure if they've published on it or not, but ideally, it would work for children with kidney, and it has worked for heart transplants in these recipients.
There was a comment by you that can use plasmapheresis, but only with lower titer.
Yes.
I mean, how much low will you say that?
Yeah. So in my what I've seen published is that for people who are for plasma pheresis, most people are not comfortable if the titer is more than 1 in 128. That's about the upper limit. People get very worried because it's difficult to remove the titers with plasmapheresis effectively to a very, very low level. So I think if the titers are 1 in 128 or less, plasmapheresis will probably work. As I mentioned, we've gone to titers of 1 in 512. So it's 2, 4, 8, 16, 32, 64, 128, 256, 512 is what we've gone to. And I think people have gone even higher than that.
Any other question? As we do not have any other questions from the audience, let us conclude this session now. Thank you so much, Dr. Zaltzman, for that interesting talk. It was very interesting and very informative as well. And thank you, Dr. Hafiz Ijaz Ahmed and Professor Fazal Akhtar Sahab. Thank you for your valuable input. Please do not forget to fill feedback forms which are available online to get e-certification for CME hours.
Yeah, thank you.
Thank you.
Good luck with the rest of your conference, and everybody have a nice evening tonight.
Okay, thank you.
Thank you. Thank you.
Bye-bye.